So we now have several FDA-approved immunotherapy-based regimens for patients with metastatic non-small cell lung cancer that lack an actionable driver. We have checkpoint inhibitor monotherapy, we have dual checkpoint blockade, and multiple chemoimmunotherapy strategies. We know that all of these are superior to chemotherapy, but they haven't really been compared to each other. So our charge now as oncologists is choosing among the available options. And I've seen some very complex flow charts, but I find it challenging to devise a straightforward algorithm here. We really need to employ a very individualized patient approach. I think we have the most options for the PDL1 positive subset. And while there are some advantages to chemoimmunotherapy in terms of response rate and progression-free survival, particularly in those first 3 months of treatment, not all the patients we see are candidates for chemotherapy. And especially during the COVID-19 pandemic, there was some value in avoiding myelosuppressive chemotherapy. That said, if there's a clinical need, a sense that the disease is advancing quickly or there's a large burden of disease, these combined chemoimmunotherapy strategies do seem more appropriate. In the PDL1 negative subset, chemoimmunotherapy remains our standard, but the data for dual checkpoint blockade is intriguing. And although nivolumab and ipilimumab not technically approved for the PDL1 negative subset, that's where its use may be most valued. Yeah, there are many factors to consider in choosing an initial immunotherapy-based strategy. With regard to the tumor, I do factor in PDL1 expression. At our institution, we use the DACO22C3 clone. There are certainly many lab-derived tests that I think are utilized appropriately. And generally, we consider three groups: 0, low, and high. There is emerging evidence that the ultra-high PDL1 expression carry additional predictive power, showing really that PDL1 expression is a continuous variable, but it's not perfect. It is dynamic. It is inconsistent. We look at other factors among the tumor. Histology is important, particularly when you're selecting chemotherapy backbone for combinations, as well as overall prognosis. Tumor mutational burden initially had some interest, but it's been difficult to interpret. And there are a lot of differences among those panels. It does not factor into my decision-making today. But increasingly, we also have to look at the host and looking at the patient. Patient characteristics are critical. Performance status, comorbidities, these are going to influence suitability for specific regimens, particularly those that involve chemotherapy. And we have to consider patient values. And I anticipate a lot of non-clinical factors as well that will come into the fold: schedule, cost, formulary restrictions, and those may end up tipping the scales when all other factors are equal. So each case really needs to be considered in its own context. Performance status does factor into my treatment decision. Patients with a poor performance status, we know, will have worse outcomes. In addition, they're going to tolerate therapy less. When I look at performance status, I try to get a sense for how quickly their performance status is changing and how much of that performance status is related to the cancer, how much of that performance status decline is, in my opinion, reversible. Unfortunately, we don't live in a world where all of our patients are PS0 or even PS1. So we have to make some extrapolation, and our comfort with that extrapolation changes, but also varies with the specific regimens that we're choosing. If we feel a regimen is relatively well tolerated and safe, even in the context of a borderline performance status, we can go forward carefully. I think we all take certain measures, maybe watch those patients a little more closely.